Uh, First of all, good evening, madam, and all my dear seniors, colleagues, and friends. Today, one more interesting topic we will discuss over here, and which is the role of muscles in pain of forearm and wrist, for which I welcome Dr. Bhaskar Patil, who is working in Topiwala National Medical College and by Yamunabai Lakshman Nair Hospital, Mumbai, as additional professor anesthesia and pain clinic. He has completed his 1 year fellowship with Ashirwad with Madam this year in this year and joined back to Nair Hospital, and now he is serving in the pain clinic patients. So welcome, Dr. Bhaskar Patil.
Yeah. Thanks a lot. So we'll begin right away with the presentation. Can you all see? Is the presentation visible?
Yes, yes, it is visible.
Okay. So our topic today is the role of muscles in various pain conditions and ultrasound guided dry needling. We are going to deal with this topic in the Ashirwad way. We are going to take a look at the forearm and wrist today. It's important to take a glance at the evolutionary history of the forearm. Pectoral fin skeletal elements of fish have evolved into humerus, radius, and ulna. In tetrapods, the forearm has been adapted for weight bearing and locomotion, whereas in humans, the forearm is more gracile and it is optimized for grasping, manipulation, and tool use. Taking a look at the comparative anatomy, the human radius ulna is parallel and allows pronation supination. This is a unique feature which enables precise tool use and manipulation. The wrist is adapted for flexibility with wide range of motion, and the hand has an opposable thumb which facilitates grasping and manipulation. The musculature of the human forearm is specialized for fine motor control with high concentration of intrinsic muscles, example the thenar and the hypothenar muscles. Other vertebrates like quadrupeds have fused radius ulna that limits forearm rotation and emphasizes weight bearing and stability. In non-human primates like chimpanzees and gorillas, they have a more robust forearm with a stronger emphasis on grasping and climbing. Reptiles and amphibians have more primitive forearm characteristics, and the focus is more on weight bearing and locomotion. Thus, key adaptations in human beings are for forearm rotation. The forearm enables precise tool use, manipulation, and grasping. Wrist and hand flexibility, it facilitates wide range of motion and adaptive behavior. And the specialized musculature supports fine motor control, which is essential for human dexterity. To conclude, the forearm is a remarkable example of evolutionary adaptation. It has a blend of primitive and advanced characteristics. It has a unique combination of traits optimized for grasping, manipulation, and use of tools. Taking a look at the bones of the forearm, there are two long bones, radius and ulna, in the forearm, which are connected by an interosseous membrane. We'll consider three joints related to the forearm: the proximal radioulnar joint, which allows for rotation and supination pronation; the distal radioulnar joint, which allows for rotation and supination pronation; and the wrist joint, that is the radiocarpal joint, which allows for flexion, extension, abduction, adduction, and ulnar and radial deviation. The forearm muscles can be divided into two groups: the anterior compartment muscles, which are responsible for flexion, pronation, and wrist movements, and the posterior, that is the extensor compartment, which is responsible for extension, supination, and wrist movements. The movement of the forearm allows for flexion, that is bending of the wrist and elbow; extension, straightening of the wrist and elbow; supination, that is rotation of the forearm so that the palm faces forward or upward; and pronation, which is rotation of the forearm so that the palm faces backward or downward. The forearm is stabilized by ligaments, including the interosseous membrane, and muscles that work together to maintain proper alignment and movement. The joint movement ranges are: at the elbow joint, flexion extension is from 0 to 150 degrees. The proximal radioulnar joint allows pronation of 61 to 66 degrees and supination of 70 to 77 degrees. And the distal radioulnar joint allows pronation of 61 to 66 and supination again of 70 to 77 degrees. The segmental movement is a special feature of the forearm in which the radius and ulna bones move in a parallel manner during flexion extension, but the radius bone rotates around the ulnar bone during supination and pronation. The forearm is part of upper limb kinematic chain, which includes the shoulder, elbow, wrist, and hand. And because of this, movement at one joint affects movement at adjacent joints. Forearm movement patterns include flexion with supination, as in grasping something, extension with pronation, as in releasing something, and radioulnar deviation with flexion extension, as in twisting. Understanding kinematics is essential for analyzing movement patterns, diagnosing injuries, and developing rehabilitation strategies. There are two main groups based on their location and function. So basically, you can classify forearm muscles based on their function, which is, you can classify them into flexor compartment and extensor compartment. And based on the depth of location, you can classify them into superficial, intermediate, deep. The flexor compartment has superficial, intermediate, and deep muscles, and the extensor compartment has superficial and deep muscles. This is a picture of the skeleton of the forearm and the wrist. Taking a look at the wrist is made up of 8 bones: the scaphoid, the lunate, tricuspid and pisiform, trapezium, trapezoid, capitate, and hamate. The anterior compartment muscles include superficial muscles, which are pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. The intermediate layer has flexor digitorum superficialis, and the deep muscles are flexor pollicis longus, flexor digitorum profundus, and the pronator quadratus. The posterior compartment muscles are the superficial muscles like extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Whereas the deep muscles include abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis, and supinator. We'll consider 4 clinical conditions: golfer's elbow, tennis elbow, carpal tunnel syndrome, and CRPS. Now, what is golfer's elbow? Golfer's elbow basically is medial epicondylitis. The prevalence is 0.4% in the age group of 30 to 64 years. In 30% patients, it begins with a history of acute injury, but in the rest 70, the onset is insidious. And the cause is repetitive overuse or misuse of flexor tendons of forearm. Risk factors for this condition are age more than 40, obese, smokers, and people who carry heavy weight. Athletes who play a lot of golf, tennis, racquetball, squash, weightlifting, basketball, and rowing are particularly susceptible to this. Any activity that requires continuous twisting or bending of the wrist may put a strain on tendons. So, certain occupations like butchers, plumbers, construction workers, regular computer users, assembly line workers, cooks, and painters, again, could be susceptible to golfer's elbow. There's some clinical relevant anatomy points which we need to take a look at. Flexor tendons of the pronator teres, palmaris longus, flexor carpi radialis, and the flexor carpi ulnaris muscles and their point of origin are located on the anterior facet of the medial epicondyle of the elbow. Cubital or olecranon bursatis may coexist with golfer's elbow. This has to be kept in mind. The ulnar nerve is in proximity to the medial epicondyle, and it could be subjected to needle-induced trauma during injection. In the middle of the upper arm, ulnar nerve turns medially, and it passes between the olecranon process and the medial epicondyle of the humerus. And continuing the downward path, ulnar nerve passes between the heads of the flexor carpi ulnaris, moving radially along the ulnar artery. So there are a lot of important and critical structures near the medial epicondyle. This is a pictorial diagram of the common flexor origin, the flexor muscles originating from the medial epicondyle. What is the pathology here? It is postulated that there are microscopic tears at the origin of the musculotendinous unit of the flexors of the forearm muscles, like the pronator teres, flexor carpi radialis, flexor carpi ulnaris, and the palmaris longus. These repetitive tearing and healing which follows gives rise to inflammation on a long-term basis, which causes pain and functional disability. And if this is untreated, it can lead to complete tear. Now, it has been postulated that combination of poor blood supply of flexor tendons and significant concentric and eccentric stresses can lead to golfer's elbow or medial epicondylitis. Now, here you can see how a healthy tendon looks, and a tendon with inflammation and tiny tears eventually leads to golfer's elbow. What are the signs and symptoms of golfer's elbow? The symptoms could be mild to severe. The most prominent symptom obviously is pain, which is localized at the medial epicondyle. It is constant, aggravating with activities like gripping of the hand, extending the wrist, pronation of forearm. The patient could experience sleep disturbances with awakening when he rolls over onto the affected elbow. There could be tingling, numbness, which radiates to the little and the ring finger, and the patient could have a stiff elbow. On palpation, there could be tenderness at or below the medial epicondyle, and there could be a band-like thickening of the flexitendons, and the grip strength is decreased. This is a USG picture of medial epicondylitis in a 60 years old male with severe tendinosis of flexors. The treatment includes rest, pain medications like NSAIDs, neuromodulators, and opioids, ice pack and heat fomentation, bracing, stretching, prolotherapy, sclerotherapy, ultrasound-guided steroid injection, platelet-rich plasma, and surgery like epicondylar debridement and decompression of the ulnar nerve. This is how ultrasound-guided injection of PRP or steroid can be carried out at the medial epicondyle origin of the flexors. Let's take a look at what is tennis elbow. Tennis elbow is lateral epicondylitis. It is basically enthesopathy, that is attachment point disease of the extensor carpi radialis brevis origin on the lateral epicondyle. It is also referred to as lateral epicondylitis or enthesopathy of the ECRB origin. In this, the elbow's outer region hurts and becomes sensitive. This is a picture which shows how the common extensor origin is there at the medial epicondyle, lateral epicondyle. Sorry. Now, the symptoms and signs include pain in the elbow, pain or weakness when gripping objects, trouble holding a coffee cup, and pain while turning a doorknob. The treatment includes surgical and non-surgical modalities. Non-surgical modalities include physiotherapy, icing, pain medications, steroid injection, PRP injection. These are the conventional treatment modalities that we're talking about. And conventionally, again, surgical treatments like tenotomy and debridement could be done. But evidence shows that these surgical treatments are no more effective than non-surgical treatments or even sham treatments. Carpal tunnel syndrome. This is the most common entrapment neuropathy. It is caused by compression of the median nerve at the wrist. Symptoms include loss of strength, sensation of pins and needles in the hand, forearm tenderness, pain which shoots up the arm, weak grip strength, and pain during the night which starts gradually. The median nerve passes between the transverse carpal ligament and the carpal tunnel and the tendon sheath which encloses tendons of the forearm muscles. Now, when there is swelling of these tendons, what happens is the median nerves gets compressed. It gets trapped between the transverse carpal ligament and the tendon sheath, which gives rise to the syndrome. The treatment include, again, surgical and non-surgical. Non-surgical treatments include bracing or splinting, NSAIDs, activity changes, nerve gliding exercises, steroid or PRP injections, as you can see in the picture. And the surgical treatment includes a procedure called carpal tunnel release, which is an OPD procedure. It is done under local anesthesia. It could be open or endoscopic. And in this procedure, the transverse carpal ligament is cut, which releases the pressure on the median nerve. Coming to complex regional pain syndrome. Complex regional pain syndrome is a neuropathic pain disorder characterized by ongoing pain disproportionate to the degree of tissue injury, which persists beyond the usual expected time for tissue injury healing. It is accompanied by sensory, motor, and autonomic abnormalities. Pain is not dermatoma or myotoma, but is regional. You can see a picture of how CRPS looks like. The symptoms and signs, there's a plethora of symptoms and signs in CRPS, basically because it's a very vague condition, but it's quite distressing to the patient. 100% of patients have pain which is out of proportion to the inciting injury. Quite lesser than that is the incidence of movement disorders, that is weakness, spasms, dystonia, myoclonus, atrophy, and decreased range of motion. Some other patients could have insomnia or sleep disorder, neurogenic edema, changes in skin color, hyperemia, hyperesthesia, body temperature asymmetry, symptoms related to the other limb, visceral pain, hyperhidrosis, burning pain, tremor, nail changes, and the least incidences of hair changes. Now, since the symptomatology is very varied, obviously diagnosing CPRS is not a straightforward job. So experts have come up with these Budapest criteria for CRPS, in which there are 4 categories of symptoms which have to be met for diagnosing the condition. When you look at the forearm under ultrasound, this is what it looks like. This is a comparison of the normal appearance of flexor compartment muscles versus how it looks in CRPS. So in the left panel, you can see the normal appearance of the forearm muscles. The muscles are quite hypoechoic and very occasional strands of fibrous tissue. But on the right side, you can see that the tissue discrimination, that is the muscle definition, is quite lost, and all the muscles have become swollen and are hyperechoic. Similarly, this is a picture of normal versus CRPS extensor compartment. Similar sort of changes can be seen here. Now, the Ashirvad school of thought says that the main pain expressors in many pain conditions finally are muscles. So what we have found is that in CRPS, there are these resting twitches which can be seen in muscles. And these are an indicator that there is something really, really wrong with the muscles and we need to address this. For the treatment, conventionally, the treatment includes pharmacological agents like systemic medications, including anticonvulsants, bisphosphonates, steroids, muscle relaxants, NSAIDs, opioids, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, and topical treatments like ketamine, lidocaine, and NSAIDs. But none of these have been proven to work for all patients. Conventionally, the treatment of CRPS includes pain medications like neuromodulators, continuous infusions like ketamine, etc., neural interventions like stellate ganglion block, brachial plexus block, spinal cord stimulation, and manual therapy, which is said to be quite helpful in CRPS. There are some novel treatments like mycophenolate, which is an immunosuppressant, polydeoxyribonucleotide, which is an anti-inflammatory, has been tried with varying results, immersive virtual reality, so that the patient gets distracted and sort of gets some sort of relief or a distraction from his pain. This is being tried right now. Microsurgery, and in extreme cases, even amputation of the affected limb is done. But again, even amputation does not give complete relief because phantom pain is known to occur even after amputation for CRPS. A 2021 comprehensive review of the complex regional pain syndrome said that it concluded that although advances in novel treatments have expanded the range of therapy options, no successful therapeutic intervention exists for CRPS. So, is it all dark? Is there all darkness for CRPS? No, there is light at the end of the tunnel. Ultrasonography guided joint healing. Dr. Lakshmi Vas, who is our guide, she has successfully treated more than 250 patients of CRPS over the last 20 years with a new modality called ultrasonography guided joint healing, which is used as a main component of a multi-modality treatment regimen. Ultrasonography guided joint healing of the entire musculature of the upper extremity is done, which includes the agonist as well as antagonist of a particular movement. It targets motor impairment of CRPS, resulting in not only pain relief, but also complete resolution of CRPS and CRPS associated disability. Stellate ganglion block and continuous brachial plexus block are also used, but only neural interventions just give partial to complete pain relief for transient duration without any disability relief. Other components of this multimodality treatment regimen are medications and physiotherapy. Now, what is the application of USGDN for forearm conditions? You have to address both the extensors and the flexors of the forearm with USGDN as the sole modality or with routine neural investigations like stellate ganglion block, steroid, PRP injections. It gives good relief of pain and associated disabilities. An extension of ultrasound-guided joint needling is injection of Botox into the affected muscles, which can be followed up by ultrasound-guided joint needling. Now, this is a good option, but the cost of Botox might be a restriction for certain patients. What are the common USG findings in affected muscles with needle insertion when USGDN is done? First is fibrosis, that the muscles could appear very hyperechoic. This generally happens at post-surgical scars when there is CRPS or there's atrophy of muscles. CRPS could sometimes show snowstorm appearance of muscles. There could be loss of muscle outline, that is loss of demarcation line in between muscles in CRPS. In irritable muscles, in many pain conditions, there could be resting twitches, not just in CRPS, in other pain conditions as well. And with needle insertion, you could elicit a local twitch reflex, which is visualized on the ultrasound. So to conclude, neuromyofascial pain can be treated effectively with ultrasound-guided joint needling. It reduces the need for opioids, invasive surgeries, and neuromodulators. It addressing the myofascial component in addition to the neural component gives near total or even 100% uniform lasting pain relief with improvement in disabilities. Ultrasound-guided joint needling proves to be an important and safe asset in chronic pain management. It opens the door for management of severe multi-site pain and associated disabilities. Hence, the final conclusion is ultrasound-guided joint needling should routinely be used along with other modalities in such pain conditions. Thank you.
Thank you, Dr. Bhaskar. That was a wonderful and elaborative presentation. Now we will move towards our further discussion and questions. So anybody has questions, we can ask.
Someone is asking to see the slide with the muscle abnormalities.
Hello. Hello. Somebody wanted to see this picture.
Sir, good evening. Good evening, everyone. Good evening, ma'am. I just wanted to see the placement of all the muscles in this slide, sir. If you can just throw some light on this. And the slide with the normal muscles that we can see the under sonography.
Yeah, that's the slide. Can you see? I've started
Yeah.
sharing.
Yeah. So can you please highlight those muscles? I mean, there.
Yeah, so basically this is the, on the left you can see a panel which shows the extensor muscles, extensor compartment muscles, which are normal. You can make out the echogenicity, which is hypoechogenicity, of the normal muscles. But on the right side, when there is CRPS, the muscles are looking much whiter. That is, there more hyperechogenicity of the muscles. And in long-standing cases of CRPS, even the size, that is the volume of the muscles, go down, which you can measure on ultrasonography.
Sir, what are these abbreviations? BR? You mean brachioradialis?
Excuse me?
Yes.
Yes.
Yes, that is
The BR is
brachioradialis.
brachioradialis.
So these all extensors are in one group there. We are not differentiating those extensors there.
Hello, can you be a little louder?
So at what level is this ultrasonography? I mean, at what part of the forearm?
This is
Usually upper one
just,
third.
yeah.
Okay.
This will be
Okay.
upper one.
And so you had shown all the, you had also shown all the flexor muscles in one of the slides. Can we see that also?
Can you see?
Yes, sir. Yeah. All right. So what, this is also at upper one third, sir?
Yes.
Okay. Okay. Thank you so much.
See, the idea here is in what happens in CRPS is as early as 15 days into CRPS, the muscles start showing abnormalities. You don't see such abnormalities in any other condition, but CRPS is such a galloping situation of ischemia and anaerobic metabolism in the muscles that there is almost a literal shrinkage of muscles within even 1 month or 2 months of the CRPS. And that is the reason why you see the hyperechogenicity. Bhaskar, can you put the slides again? I will say with the slide.
And ma'am, can you please also throw some light on what is the how does this dry needling work?
Yeah,
in
I will
resolving
explain.
this issue? Yeah.
See, if you look at the left slide, where you can you put the flexor slide? Flexor slide, please. This is the extensor. Yeah. See, in the flexors, you can see that the outlines of the muscle is very clear. It's bright and white. Whereas the muscle is looking black, mainly black, with streaks of white. And this is very typical of normal muscle. But if you look on the CRPS forearm, you can see that the outlines are very unclear. And many times you can't see anything. It's just like a mass of white there. So you see, I saw this ultrasound changes somewhere in, I think, 2011 or something like that, 8, 9 probably. I was literally blown away when I saw the kind of difference that there was. So why does this happen, and why does ultrasound guided dry needling help? So that has led to a totally different understanding of CRPS. I believe that in CRPS, the primary issue is the motor impairment, not the pain, not the the sensory symptoms, nor the vasomotor and pseudomotor symptoms. If you look at a CRPS forearm, the vasomotor and the pseudomotor dominate the scene. In the sense the hand is swollen and it is hot and red, and the patient is usually in a lot of distress pain wise. But all these are actually red herrings. The main problem is in the forearm muscles. And if you look at a patient, the forearm muscles, in the forearm, there are hardly any symptoms. All the symptoms are in the hand or in the foot if it is lower extremity CRPS. This is because these forearm muscles which are affected by CRPS, they go into co-contraction, severe co-contraction. When I say co-contraction is a normal phenomenon. It is used to fix a joint sometimes for a stabilizing another movement. Like the wrist is fixed in this position so that the hand can do writing or whatever it is. So that is normal co-contraction, which is painless, it is voluntary, and it is reversible at will. Whereas what happens in CRPS is that it is so tough and it is very abnormal. In the sense, if can you see my hand, all of you?
Yes, ma'am.
Is my hand visible? My hand is visible?
Yes, ma'am.
See, in CRPS, the patient will be struggling to even do this, struggling to do flex the hand. This happens because as the flexors are trying to bend the finger, the extensors should relax. In CRPS, because of the co-contraction, the extensors go into a contraction instead of the reciprocal inhibition, which is normal. As a result, the patient struggles to either flex or extend. And what happens is that co-contraction leads to a tenosynovitis of all the tendons of the hand. And it is this tenosynovitis which masquerades as the vasomotor and pseudomotor symptoms of CRPS. And because the co-contraction is a 24/7 phenomenon, it leads to destruction of the muscle, which is seen as hyperechogenicity. See, a normal muscle fiber looks hypoechoic, whereas when the muscle tissue disappears from within the framework of connective tissues, the connective tissue which looks like a streak of white in a normal black muscle, the connective tissue framework predominates, and that's why it looks as if it is hyperechogenic. So that is the pathology, that the muscle disappears because of the constant co-contraction. Once you understand that constant co-contraction is the culprit, if you go and do dry needling of the two sets of muscles, the agonist and antagonist, automatically the muscles start becoming, what shall I say, more mobile. And the tenosynovitis disappears after 2-3 sessions of needling. And as a result, all the swelling over the forearm, when hand disappears, the patient starts sleeping, the pain goes down. And after 5-6 sessions, the pseudomotor and the vasomotor symptoms disappear. So what we are told and what we are taught about CRPS is all, the it's a inflammation. The inflammation is in the spinal cord, which mysteriously tracks down the brachial plexus and the nerves into the hand to produce inflammation in the hand. If you ask me, and if I was to be politically incorrect, it is all absolute BS with capitals, in capitals. What happens here is co-contraction of the agonist and antagonist muscles, which causes tenosynovitis of all the tendons of the forearm, both the flexors and the extensors. And that is the reason why you have this swollen hand. Once you start doing dry needling of these muscles, automatically all the symptoms come down. Not only do all the sensory, vasomotor, pseudomotor symptoms come down, the motor symptoms come down. And so we go from a situation of lot of motor impairment to much better state. And finally, the disability completely disappears and work ability comes in. So that is why ultrasound guided dry needling is in fact, it is the best thing that could happen to a CRPS arm. And initially when I started, I used to do, stellate ganglion. By the way, with all this, why does stellate ganglion work in a co-contraction situation? This is because there is a lot of sympathetic maintenance of pain in CRPS. You have to understand that the muscle has a huge sympathetic innervation. And when there is co-contraction, ischemia, there is actually chaos going on inside that muscle. As a result, it will produce a lot of sympathetic recruitment, and the pain also becomes sympathetically dependent. So when you go and do a sympathetic ganglion block, the pain goes down for sure. And many times even the pseudomotor and vasomotor symptoms come down. But the motor does not respond so well. And that is the reason why when you give a stellate ganglion block, it works probably for 3 months, or maybe in a good case, maybe 6 months. Or in a bad case, it may last hardly 15 days. But the motor problem of co-contraction brings back all the symptoms. So,
ma'am,
okay, let me go into this. Yeah, let me explain the 2 more things in this, and then you ask me the question. So initially, I started with stellate ganglion block, and I didn't trust stellate ganglion block to do all my work. So I used to do continuous brachial plexus block as well. So with this, my patients were very happy, completely pain-free, but they would be struggling. They are completely pain-free. And I'm trying to do this to their hand, but their hand will not bend. The fingers will not bend. So I knew that there is something wrong with the muscles, or there is something wrong in the hand, but I could not figure out. For almost 6-7 patients, I could not figure out. With the 8th patient, I said, I'm going to do needling in this patient to see what happens. The moment I did the needling, it was like magic. The hand started bending. In fact, she was a person with a lot of shoulder issues, and she could do this. So then after that, that thought process started. And to arrive at co-contraction, it took me a long time. So this, I have learned CRPS on the job from my patients. Whatever I'm saying, there is nothing about it written in any textbook or anything. Of course, my papers talk about it. Yeah, now you can ask me your question.
Thank you, ma'am, for such an elaborate explanation. Now, the next question that comes to my mind is that there is a high autonomic nervous system component in this also. But at the same time, you're saying that definitely I can understand this co-contraction state. Have you seen any kind of side effects on the autonomic nervous system, or a stellate ganglion block is an urgency, and along with US guided dry needling, it is a requirement? Is it a requirement for sure?
See, stellate ganglion makes it easier for the patient. With my needling, I can bring the pain down, but it takes about 3-4 sessions and it is painful. If I give a stellate ganglion block, it brings down the pain very quickly. And it's like magic when you give it. You know, it just the pain goes down immediately. The swelling and other things take some time to go. So then after that, for you to do the needling, it makes it much easier. So from that angle, stellate ganglion block is useful, but it is not curative. The curative treatment is ultrasound guided dry needling. So that you can do the stellate ganglion block and then do dry needling, or in patients who are very, very high, what shall I say? They say, I can't tolerate needles at all. Then continuous brachial plexus block will provide the anesthesia for the needling. But ultimately, neither stellate ganglion nor continuous brachial plexus block will reverse CRPS. What reverses it is needling. But you can make the patient's life much easier by doing the stellate ganglion block or continuous brachial plexus block. And then there is a condition called as sympathetically independent pain. In such patients, which happens in the later stages of CRPS, if you give a stellate ganglion block, there is no difference at all. So these are not going to be helped by stellate ganglion. But even this category is helped by ultrasound guided dry needling.
Thank you, ma'am. Quite amazing. Yeah.
Yeah, it is amazing. If you see all the, patients as they reverse, it is awesome actually.
I wouldn't have even thought of doing dry needling in an autonomic nervous system patient involvement, so it's quite amazing for me. Thank you so much for throwing
No,
that.
don't worry. I was also equally reluctant to do needling in CRPS. That is why I dawdled for about 7 patients. 7 patients, I must have seen them over almost 6 months or 8 months, but I didn't do needling in these people, in these patients, because I also believed, like you, that this is an autonomic condition. See, anybody who reads about CRPS is sure to be in for confusion. The literature is so confusing. And at the end of reading a whole chapter very sincerely, you know nothing about CRPS. That is usually the experience. And so I also thought it is all autonomic, it is neuroinflammation, that this, blah, blah, blah. But then I did the needling and it was a hey presto kind of moment.
Thank you, ma'am.
Yeah.
Any other question? Anyone? Okay, I would like to share one of my experience. When I just had completed a fellowship with madam, 1 year fellowship with madam, and started our pain clinic in Nair Hospital. And then one of my family member, my bhabhi, she developed lateral epicondylitis, and she told me that she had this tennis elbow and all. She diagnosed. She went to ortho. She said, I advised her that I will do her needling, But then she was scared and she said, no. I will go to the orthopedician first, then I will see. Then they started with her pregabalin, painkiller, everything. First 7 days, she was very happy with pregabalin. Then towards the month end, she was very this thing because her pain was increasing and disabilities also started increasing. So she couldn't do normal household work also. Then they advised her some steroid injection or surgery. Then she got scared. Then she just asked me, "Okay, Didi, you do the needling for me." So and she was very apprehensive for needling also. And I did her all the muscles of the lateral epicondylitis extensor. Even her flexors were started getting this thing painful. So I addressed her all the muscles, and only one session I did. She was not at all a good patient, cooperative patient for me, and I couldn't even put more needles, whichever is the needed. But then this happened before COVID, I think 6 years back. Till now, till now, she's very happy. She, I mean, that one session and at the end of her pain and disabilities also. So that is my experience. And even last year, my father had stroke, and he had quite a very bad distinct difficulties. His gait was also not good, and he said, do the needling for me. So I did needling for him, and he miraculously recovered in maybe in 8 days. And now he's walking, he's going out, he's very well. So that is my experience. So those are the miraculous effects of ultrasonography guided dry needling.
See, actually, this co-contraction, it looks like a mechanism for many problems. That is the reason why I think your father also recovered from a stroke. Again, in stroke, what happens is, it is the flexor dominance which comes back. But the extensors are also trying to recover in a stroke. And it is a higgledy-piggledy kind of a recovery, which is why they have motor difficulties, as well as later they develop that posture like that. So when you did the needling for him in the early stages of a recovery from stroke, that is actually one of the best things you can do for a stroke patient. So in fact, all these things I have explained as cases in my book, because it was, the first 10, not even 10 years, I think first 5 years of my practice with needling were like, feast for me. Every day I see some patient, I treat, I stick needles into them, they do well. But my problem was always, why are they doing well? You see, these are all they have such very highly sophisticated descriptions in books, which is very daunting, you can't even understand half the explanations in those books. And then I go and stick a few needles here and there, and the thing is done. So I used to wonder, why am I producing results? So I have had to develop my own thought processes about what works, why it works, and how it works. So all that I've tried to put it in that book, but it is obviously not very comprehensive, but it is there, especially about the stroke. And CRPS, I've given a total detailed account in that book, because I have described it like, as I discovered the facts about CRPS, I have described it. So anyway, hand is one of the areas which I think which became a very strong place for me because of CRPS. And Bhaskar, very nicely done presentation with the following of the evolution and evolutionary changes. I think it's not just the hand, everything in the body has to do with this evolution. So if you go back to evolution, you will in fact understand many of the things which are which are, today we are in. Like I think I was looking at biped to from quadruped to biped posture. So something like they were saying, what we have, human beings have as pain, are pain of imperfections. Yeah, imperfections created by the evolution.
Evolutionary anatomists say that this is the price that we pay for being bipedal.
Correct, correct. And see, with the bipedal thing came the skill development. As you said, the other animals don't have a separate ulna and radius. They have a single bone to provide stability. So, there it is more of a strength. Whereas with human beings, it's less strength, but more dexterity. The kind of dexterity a human hand has, you have to see a CRPS patient to understand how dexterous we all are. The way they struggle even to hold a coffee cup or to do, simple acts of life are so difficult for them, poor things. So anyway, that is, we are unaware of all the gifts we have.
Ma'am, there's a question by Dr. Prashant. Post brachial plexus injury, patient get operated after 3 months. Recovery is very delayed, but till that time, patient develop contracture. Any role of USGDN?
100% role in USGDN. See, I saw some, I was in my own private practice, I had not seen brachial plexus injuries much. But then after I started going to KEM hospital as an honorary, I would see the brachial plexus injuries there. And I said, okay, let's do the needling and see. Because my understanding was that if you put an ultrasound on brachial plexus injury for, in all these conditions, it's like a whiteout. It's literally, there is not a single strand of muscle in these patients. And then, but then you have to understand the connective tissue framework inside the muscle also has a part of, some amount of elasticity. And then when you put needles into it, somehow it acts like a growth factor, what shall I say, initiator. When you put a needle, there is probably some bleeding and some platelets come in there into the connective tissue framework. So little bits of muscle start appearing in the brachial plexus injury patients in the forearm. And so over a period of time, some amount of, muscle power comes in these patients. It has nothing which you can compare it to a normal muscle or the normal hand. But they do develop some kind of movements, some kind of strength. And then when we catch them earlier in these brachial plexus injuries, many of them go for good recovery, because in the recovery period of a brachial plexus injury, they go for something like CRPS. Because again, you have to understand there is a neural injury here at the brachial plexus level. It might be preplexus, postplexus, etc. Depending on that, there is an injury to the nerve and the motor fibers may be spared. So they are waiting to recover actually. The nerve fibers are recovering. The muscles that they supply are just abandoned by most doctors, because you see, everybody is trying to focus on the nerve and repair that nerve. What is downstream of that nerve, most people tend to ignore. But if you start doing needling, you will discover many of them have this co-contraction again. Some of them are actually CRPS. They are brachial plexus injury, but the injury is not severe. But the muscles have gone into co-contraction. And so if you go and do needling in them, the CRPS part recovers. And their brachial plexus injury is not really significant. But because people do not acknowledge this co-contraction and other things. They assume a person with a brachial plexus injury who is unable to move his hand or her hand, it's because of the injury. But I have reversed more than 2, 3, 4 patients at least I have recovered. I mean, I have reversed in the sense they had brachial plexus injury, but after needling, these patients got full dexterity back. And so that was amazing to me. And also there are some people, you see, it is the muscle tissue which gives them pain. So even their pains go down when you do needling in brachial plexus injuries. If I'm not mistaken, I saw 11 patients of brachial plexus injury in that 1 year before COVID. And in that, only one patient didn't recover. He was, I think, brachial plexus injury some 2 years before, and he was in a very negative frame of mind. Whereas the others were probably a little more recent, and they recovered quite a lot, and their pains went down also. So whoever asked me this question, if you are someone who sees brachial plexus injuries, start doing needling and present your data to us.
Ma'am, the 2005 paper by Jay Shah, in vivo microanalytical technique for measuring the local biochemical milieu of human skeletal muscle, wherein they use microdialysis needles to find out what exactly happens when skeletal muscles are needled. So this paper describes what you just told us. I think it's worth reading for all practitioners of ultrasound guided dry needling.
Yeah, yeah. See, there are so many things which we don't understand, and there is so much to know about muscle. And today only I was discussing with Janvi, where does the pain from muscle go? I mean, which nerve fiber carries that pain? Is it is it the sensory nerves going to the dorsal root ganglion, or do the pain impulses from a nerve, I mean from a muscle, do they travel in a motor nerve? This has been a doubt for me for a long time, but I have asked anatomists, and they are unable to give me an answer. If you read Gray's anatomy, it shows very clearly that muscle has an abundance of free nerve endings and temperature nerve endings. So that is probably one of the reasons why many times muscle pain also presents as a burning pain. So there is a lot of basic research to be done in muscle, but for that we have to get people to sort of acknowledge the importance of muscle in chronic pain. So I don't know whether it will happen in my lifetime, I will say. But anyway, we keep working.
Recently, I've read an article from Tom Mayer, an anatomist, who talks a lot about 80% innervation from the fascia to the muscle. So he's like the muscles are cradled into the fascia. So and fascia is like rich with sensory innervation. So that could also be one of the things that causes the. I mean,
the fascia is very sensitive, and also the intermuscular facial compartments are the places where the nerves travel. So the fascia is very rich in innervation, and so also the muscles. See, muscles, we all assume that they are like some kind of furniture meant to do our bidding. It is not just that. I believe it is nature's building brick for pain as well as for survival. See, if the primitive animals could not run away from their predators, they wouldn't survive. So, and if they didn't have pain, they would not pay attention to their whichever area is hurting. So nature, what it has done is that it has linked pain, which is a survival sensation, along with the locomotor system, which is which is essential for the fright, fight, flight reflex. So this is fight, fright, flight reflex is muscle, and pain is also muscle, and both are linked. So muscles are the building bricks actually for pain. And this is a basic funda which is missing in the current pain literature. Because current pain literature is dominated by neurologists. And we pain specialists are just inheritors, you know. We are anesthetists who don't know much about anything, really. Other than anesthesia, we don't know much about pain, nor do we know anything about the diseases. We don't know orthopedics, we don't know neurology. We know a little of everything, but we have not really focused on these. So the pioneers in pain management have been orthopedicians and neurologists, but they had no interest in pain. To them, it was a pesky, stupid complaint. So whatever they have thought about is, with their peripheral vision, it was just handed over to us who took over pain management. Simply because we are good at doing nerve blocks, we were given pain management, the status of a pain specialist. Honestly, we are not. But we have to learn on the job, literally. So the IASP, the special interest groups, and all the important people, there are a lot of neurologists and, of course, a lot of pain specialists, none of whom wish to acknowledge muscles. Somewhere, muscles have to be acknowledged, and then only basic research will start. Someone like Tony Aksh, what wonderful research he's doing on nervous system, about microglia and so many other things he's doing. We need that kind of a research about what is the nerve supply of a muscle which carries the pain from the muscle. We know that the muscle has proprioceptive and kinesthetic nerves, innervation. But what about the sensory innervation of a muscle? We are very familiar with the efferent nerve endings in a muscle which makes it contract. But the pain felt in the muscle, which is the nerve which carries it. So there is a lot of things we need to understand. We are at the literally very basic stage of clinically understanding that muscles are important in pain. USGDN helps in relaxing the muscles and correcting that pain. So we are doing really very, very basic work in pain. But it is from this basic work that ultimately more sophisticated understanding has to emerge.
Any questions?
That's true, madam. That was a wonderful explanation, madam. Thank you so much. Any other question? I think there are no questions.
Okay, can we wind up then?
Oh, okay, madam. Okay. Thank you,
Okay.
Bhaskar. Thank you, madam.
Thank you, Bhaskar.
Good,
And thank you, Varsha, for coordinating.
good night, madam.
Good night.
Good night, all. Thank you.
Good night, everyone. Nice presentation, Bhaskar sir.